any discussion about life has to, or death has to have a discussion about life in addition. What the meaning of it is. You'll find people that will have the meaning in their hands and will say, this is what it means. This is what life means. But I don't think anyone really understands truly what life means or what our deaths mean. It's a very confusing thing, and religious people have told us many different things about it, but I don't think anyone truly knows. When you look at the planet, Earth, and you say, well, this planet's been here for 4 billion years, and our lives are about 100 years of that time frame, and how we can, as humans, think that we know everything about what it all means. It's very difficult to know. It befuddles us at times. And so it's the question of dying and the question of death is one of those difficulties that brings back the idea of what it all means. And so you think of this planet that we live on and the 4 billion years it's been here and the 7 billion people on this planet, and we're all just in the realm of time, just passengers on a very short trip. And so that's the prelude to advanced directives.
Can you turn the audio up?
There is no audio. I just have to talk louder. So I'll use my my in-house. I have 2 kids, so I can actually raise my voice pretty loud sometimes. So we all pass. We all die. It happens. We can't control it. There's the best case scenario and the worst case scenario. I put up 2 different situations. And so the best case scenario is we die in a comfortable setting, and most of us, that comfortable setting is home, and comfortable setting is surrounded by people that we love. One other thing most people would agree with, they don't want a lot of suffering. They don't want a lot of pain when they pass. When you come to the end of your life, you also want to say, well, it's been good. The whole experience has been wonderful. I enjoyed every part of it pretty much. There was suffering involved, but I enjoyed the whole thing. And I'm at peace with the whole process of life and the whole process of death. That's hard to do. And the ones we love, while they're sad that we've passed, they're at peace with it. The ones that we care about, the mourning is not so much so that they're debilitated, that they suffer too much. And then also that we have the choice about what type of health care we want at the end of life. So that's the best case scenario. The worst case scenario is that we die without saying goodbye to the ones we love. That we have a lot of pain, that we have dissatisfaction for the life we led, that we came to the end and we wanted more out of it. That didn't satisfy us. That we're angry at the prospect of our death. And that our children or other family members fight for life-sustaining measures for us, that they struggle with it. And that we have no choice, that let's say we end up in the hospital and we have no decision-making ability or ability in the end to make any choices about where we want to go and what direction we want to go in. So worst case scenario, best case scenario. Best case scenario, you die. Worst case scenario, you die also. So they go to the same place, but you come to the same. You may want to get there in a better way. So it's good to have knowledge about what happens in the hospital, what happens, and what portends an unlikeliness of things getting better. So most Americans want to die at home. 70% of Americans, if you do a survey, want to die at home. Those with chronic illnesses, diabetes, high blood pressure, cancer, 80% of those people want to die at home. The percentage of Americans that actually die at home is about 24 to 33%. The 33% is actually growing. It's actually more people, because of hospice, are dying at home. And that's Medicare beneficiaries, the 33% that comes from. So people are accepting more the situations of hospice, and more people are dying at home. But a lot of people die in the hospital, and a lot of people die in nursing homes. More than 4 million people are admitted to the intensive care unit every year. And the most common reason why people go to the intensive care unit is because they have difficulty breathing. They have respiratory failure. They have to be on mechanical ventilation. Another fact is that 1/3 of all of our medical expenses are spent on the last 2 years of life. So a lot of this ICU care, being in the intensive care unit, it costs a lot of money. And frequent hospitalizations cost a lot of money. And then about 10% of Medicare patients will get mechanical ventilation before they die. So 10% of people over the age of 65 will be on a ventilator. So being on a ventilator, this is what it is. And not the greatest picture, but this is the typical ICU bed. Typical, you can't see the machine. The machine is, to the pointer, is off right over here. But the blue tube's going into another tube, which goes into your mouth, and it breathes for you. And for many circumstances, that's appropriate. You're short of breath, you're suffering. I mean, you can't breathe. This is going to save your life. It's going to give you oxygen. It's going to help you open your airways. So, facts about intubation. So, percentage of people who are admitted to the ICU who get ventilation, it's about 33 to 40%. And of those people who get ventilation, 10 to 15% of people will actually not be able to get off that ventilator. They will not be able to breathe for themselves. And that being longer than 3 weeks. So the problem with that is you're on a ventilator for a long period of time. Your chances of survival past that time are quite low. The survival rate, I quoted a number of 31.7% after 1 year. So prolonged ventilation does not really lead to a good chance that you're going to survive past a year. So after you're on a ventilator, but the other problem with being on a ventilator is you can't keep that tube down in your throat. It won't be good because it wouldn't be good because you have a chance of infections. So you actually have to get something called a tracheostomy. Has everyone seen a tracheostomy? Know what a tracheostomy is? So, and that's where you actually make a hole right here in the trachea, and you open up an airway, and that same tube that you saw that was connected to the ventilator is now connected to this tracheostomy tube. And that opens up your airways, and it gives you oxygen. And for some people, especially people who are involved in motor vehicle accidents or who have sudden swelling around the neck, this is life-saving. So this is a tracheostomy. But for some people, this is what happens after prolonged ventilation. You need to have this done after 3 weeks. So that's tracheostomy.
May I ask a question?
Yeah.
Can you talk after you have a tracheostomy?
You can talk, but your phonation's not very good. It's basically you need some airway coming from your mouth to cause your vocal cords to vibrate. So you can talk, but it's not as good as you have to also plug the tracheostomy tube to
Be able to do that. But
to do
I know
that.
that you cannot speak when you have it down your throat.
No, that's quite difficult. Yes.
And what is the risk of getting infection with tracheostomy?
Less so. You can get localized infections usually around the skin around here. And the other thing is, you have one of these machines, or the tracheostomies, there's mucus that can develop there, but it can be cleared with a suction tube. So they suction out the mucus from the area. So that's breathing, but we have to all have nutrition. So if we don't have nutrition, what's often started in the intensive care unit to get nutrition is a tube that goes from your nose down into your stomach. It's called a nasogastric tube. And that tube gives you nutrition, but you can't have that tube for a long period of time for the same reasons, especially in regards to infections around the nose. So what is often done is a gastric tube, a tube feeding that goes directly into your stomach. Now this is, again, for people who have been in this situation for a long period of time and need to get nutrition, and they get nutrition from a feeding tube that goes directly into their stomach through a hole in their skin that goes directly through their stomach. So, okay, so then all this happens, and none of this sounds fun. But then, where do you go from here? And most often people go to nursing facilities. And nursing facilities, there are so many of them, and the census of them is about 1.7 million people reside at any one time in a nursing facility. Stays, can be prolonged depending on your level of debility and your ability to rehabilitate yourself. But prolonged stays, while insurances do cover it to a certain degree, Medicare does not cover it. And after a certain period of time,
Medicare does or doesn't?
up to 100 days. I'm sorry. Yeah, it's 100. Okay, it's 100 days. So, and so then stays can be prolonged, but after that 100 days, then there's an amount of money that you would have to pay for the nursing facility. So what causes people to stay in a nursing facility for a long period of time? What causes people not to do well in regards to their survival? If they were in the ICU, if they were on a ventilator, what aspects can cause greater chance that they won't do well? And one thing you can't do anything about, it's being over the age of 65. I mean, we can't control this. You get older, and that's something that is a negative risk factor. Having bed sores, and bed sores are basically lying down in bed for a long period of time. You get ulcerations that develop from just being in one position for a long period of time. It's basically saying you're not moving so much, you're getting ulcerations, and that's a negative factor. Having kidney failure is a factor, whether being on dialysis or having near dialysis. That is also a factor that can cause problems with survival and problems of trying to get out of a nursing facility. If you're on a ventilator for longer than 3 weeks, that's another problem. And then the other thing is having a stroke, a bleed in the brain, anything that causes neurologic damage within the brain. That's another reason why you may not do very well. So it's something to keep in mind, especially if you're going to be thinking about an advanced directive. It's something that you can even specify. If I have kidney failure, if I have a massive stroke, if I have a bleed in the brain, and I'm not able to, recover, if I'm on a ventilator for a long period of time, don't keep me around. That is something to think about.
Excuse me. The number 3, the kidney failure, that would be for people who are
On dialysis and near to the point of dialysis.
Okay, but other people don't.
If you have mild kidney insufficiency, no. Like let's say you had mild kidney problems, it's not applicable.
All right, thank you.
So advanced directives. So you have all of you have them. They're called living wills, personal directives. There's 2 big portions of it. The first portion is assigning somebody to be your power of attorney, finding someone who can make these decisions for you, and then the second point is choosing the direction of your care. So there's 2 portions, and so first portion is choosing an agent, choosing someone you trust, who understands who you are and understands your wishes, and that's sometimes a difficult thing because sometimes in our society we have a lot of disconnect. We are often doing our own things and we're not as connected with our families as maybe we were 100 years ago. So that is sometimes a difficult thing, and family is a difficult thing. This is my family. And this is a big family, and this is a few years ago. I had hair in this picture. And you think about all the different people and all their quirks and all their differences and what they want and what they choose may be different for each different individual. But family also has issues. But I bring up a point I want to, in regards to family, because I have this was my grandmother. She was in the farmer's market accident, and this was in Santa Monica, and she fractured her spine, 3 of her vertebrae, totally unstable. We thought she was going to be paralyzed. This was she was 89 years old. And she'd been going to the farmer's market every single Wednesday and Saturday.
Somebody tripped her?
No, she was hit by a car, and yeah, about 10 years ago. She and flew and then hit a tree, and so she broke 3 of her vertebrae in her neck. Both of her lower legs were fractured. And we were thinking, she's possibly not going to survive this. And we had the whole family. I mean, talking about what to do. I mean, should we let her go, or what kind of life would she lead? We were lucky. We had a great spinal surgeon who actually was able to fix what was going on in her neck, because we thought she was going to be paralyzed. And if she were going to be paralyzed, we didn't think that she would want that kind of life. But she did survive. She did actually do well. And that was a decision that the family understood, that she didn't want to be kept, if she were going to be paralyzed, she wouldn't want to be kept alive. But if there was a chance that she could survive, we were going to give her that chance. So she did survive and actually did walk again, and it was great. She had another 3 years, but after 3 years, she noticed that one day her belly was getting swollen. And her belly, she was now 92 years old, her belly was getting swollen. And she was having a lot of pain. And she went to the hospital. And in the hospital, they removed the fluid. There was massive amounts of fluid in her belly. And it was realized that what was going on is she had a cancer metastatic, probably ovarian cancer that was causing this. And she had been losing some weight, and she hadn't been doing well. And she was comfortable with the idea of her own death. She didn't want any miraculous treatments. She didn't want any chemotherapy. And she talked to my uncle, Uncle Danny, and my uncle was the decision maker for her. And he made the decision, and along with her, that they weren't going to prolong this. They weren't going to do any amazing types of therapy. They weren't going to do any kind of surgeries for her to actually relieve her bowels from twisting because of the cancer. And so she was in the hospital, and the decision was to let her go. And what was done was morphine was given to make her comfortable, and everybody in the family was told, and all of her friends were told, this is going to be it. She's going to die. And the day before she died, she probably had more than 100 people come to visit her and to say goodbye to her. And to think that she had control over that situation, to be able to control that, to say, okay, I'm at peace with this, I'm at peace with dying, and to everyone to say goodbye to her, and everyone else to be somewhat at peace with her going too. That was a wonderful situation for her to pass that way. And so family can be a good thing and sometimes can be a bad thing. Sometimes family can fight. Sometimes family can have disagreements between children about what should be done. It's good to have somebody that you feel that you can trust to make those decisions. So if that one person is unavailable, or you want to make an alternate agent in addition, you can make an alternate agent, whether it be another family member or a friend. You can do that also. And so, if your agent is, let's say, in Zimbabwe, the alternate agent will be able to make decisions. So your agent's authority, what can they do? Well, basically, if you're compos mentis, if you're doing okay, if you're able to talk and you make your own decisions, you can make your own decisions. So that agent can be there, but you can make your own decisions. Now, on the advance directive, you can say, I want the person to make decisions right now. And you can mark an area in the box, my agent's authority to make healthcare decisions for me takes effective immediately. So you can say that, or just leave it blank and make your own decisions. But if you're not able to talk for yourself to communicate, then that agent will make decisions for you. And that agent's obligation is to make those decisions based on what you would want. And that's something you would have a conversation between you and your agent about. And also that agent has the right to also what to do with your body afterwards. Yes?
Are these members of the family, both of these agents?
It can be, it doesn't have to be. It could be a really good friend. It could be a niece. It could be anybody.
And where do you put their authority?
Actually, it couldn't be your doctor.
Or it comes through the doctor?
Yeah, no, it can't be your doctor, but
Oh, how do we put the agents in authority on the list of things and your paperwork?
what you want them to do or not do, or what you would want?
And is this one of the directives that you have for POLST or something like that?
Yeah, POLST is a different type of form, and I'll go through a POLST form. I have a sample POLST form also. but it can be confusing, right? Okay, so now that first part is your agent. Now the second part is what you want, and that can be a little confusing. I mean we all want to live as much as possible. I mean, I think of a joke where you have people who are at their deathbed and what they want to have said about them, and you have a rabbi who wants people to say, oh, he was a great person, he gave to the community, he was loving, and a priest who says, basically people that come by and say the same thing, that he was a good man, he did cared, and then you have Woody Allen, and Woody Allen, who wants people to say at his at his coffin, people to say, look, he's breathing. And we all want to live as much as possible, but it can be confusing. So yeah, there's a choice not to prolong life and a choice to prolong life. There's an A and B. So I'll read this to you. I do not want to prolong my life to be prolonged if I have an incurable, irreversible condition that will result in my death within a relatively short time. Well, that relatively short time can be, well, what does that mean exactly? That's a relatively short time. Well, what does that mean? A year, a month? What does that mean? I become unconscious, and to a reasonable degree of medical certainty, I will not regain consciousness. Well, that can be, you have neurologists who make the assessment on that, and you have doctors who make the assessment on that. And that's reasonable. But the likely risks and burdens of a treatment would outweigh the expected benefits. Well, who do we trust in regards to that? We trust doctors to make that assessment for us. And sometimes doctors will feel, well, your cancer will respond to the chemotherapy. I mean, you'll be dead, but your cancer will respond. The risk, it's hard to know exactly. Sometimes it can be confusing because you have doctors who actually differ in opinions about what can be done. So that's choice A. Choice B, choice to prolong life. I want my life to be prolonged as possible within the limits of generally accepted medical standards. Well, okay, now I don't know what that means either. What are the medical standards? People may be kept alive for a long period of time. You can be kept alive with a ventilator, a defibrillator. A defibrillator is a machine that actually shocks your heart out of abnormal rhythms, or with a pacemaker. These things can keep you going for a long period of time. So the generally accepted health standards that's a moving target. It's hard to know exactly what that means. And then the other portion of it is relief from pain. Basically, most people say that they want relief from pain if they have pain toward the end of their life. And then also the option of what you want with your body. If you want it to be donated, if you want your tissues to be donated, for some smart, like myself, I want my whole body to be donated. I think I'm a medical marvel now. But what you want to do with your body, I'm just trying to be funny. So that's the advanced directive you have. What I like actually better than the California advanced directive that you have is something called 5 wishes. And does anyone know what the 5 wishes? People know what?
Where do you get it?
You can get it actually online. You can order it online. I'll give you the information about it. There's a website where you can get it. So what life support means, and basically it's any kind of life-sustaining measure, and that's something you have to define what you would want. Would you want to be on dialysis? Would you want to be on a ventilator? Would you want to be shocked and have CPR to actually revive your heart? would you want these things? Would you want some people define life-sustaining measures as just getting intravenous fluids, or what would you define as that? And you can put that here. For me, I just put down everything. So what they define here, which is a little bit different, they give you 4 different options. And some of these are a little bit redundant, but what it says is, like, if I'm close to death, if my doctor and another healthcare professional both decide that I'm likely to die within a short period of time and life support treatment would only delay the moment of my death, what would I want? And I want to have life supporting treatment if my doctor believes it could help. But I want my doctor to stop giving me life support treatment if it is not helping my health condition or symptoms. But you can also say, I do not want life support treatment. I want life support treatment. So you can mark 3 different options here. And so then the other aspect is, like, if I'm in a coma and I'm not expected to wake up or recover and I have brain damage, you can define the same 3 things. I want to have life support treatment. I do not want to have life support treatment, or somewhere in the middle. If my doctor thinks that I have no chance of survival, I do not want to have life support treatment. The same thing for permanent and severe brain damage. And then also, then you can then define if there's another condition that you think you want to have life support treatment or you don't want to have life support treatment. And there's a space where you can write it. And so, since I still think I'm 15 years old and I bike ride and climb mountains, and I worry about hitting my head on something and having, traumatic brain injury that leaves me unconscious. So I put information about traumatic brain injury and what I would want if for traumatic brain injury. And so what I've read is that people can come out of it after 6 months. And so I want to be kept alive for 6 months.
So what that says is on a ventilator for 6 months?
Basically, to keep me going for 6 months.
That's a long time.
It's a long time. It's a long time. That's the only time I'm doing that. But I just think that it could happen to me because I do silly things. But maybe I shouldn't be doing silly things.
It's a valid concern because people could be in a coma. Medical conclusions or recommendations would say, this is the end to the family.
Right.
And the family is reluctant to accept that. And the next day the patient revives.
Right. The other aspect of it, I should have written this down, and I didn't really write this down. I should now that didn't make me think about it. If I have a major bleed in my brain, if the trauma to my brain is actually I've bled into my brain, and my brain is squished down to basically nothing, then I don't want to be kept alive in that circumstance. But this is just for an episode of having traumatic brain injury without a major bleed.
How are we as non-medical people going to have that kind of information?
Right. So so that's brain trauma. But so you could put there if I have kidney failure, don't allow for resuscitation, don't allow for shock, don't allow for CPR, don't allow them to put me on a breathing tube. You can put that there. It's just, to some degree, being informed of these things. Yes?
Is an advanced directive that follows sort of format to be accepted or at least not confuse them?
A format?
A format like what you're showing, and apparently this is a good way to do it.
There are people who make their, they make their own.
That might compromise the integrity Is there any advanced directive that might not be acceptable to the medical profession?
Some states don't accept some other states' advanced directives, but for the most part they do. And if you write down, let's say you have a living will, and you write down all your wishes on that, those are your wishes. And if it's been witnessed and it's been signed, that should work. So then I said, okay, now it's number one. The number two is if I have cancer. If I have cancer that's, let's say I had stomach cancer, and it was outside the area of my stomach, and it went outside into other areas of my body, my lungs or anything like that. And I said, in that circumstance, I just want to be on life support for about 2 weeks. And if I'm not able to come out of it, take me off. If on the second episode it happens again, I only want 2 days. And on the third episode, just don't do anything, because this is not going in the right direction. And then the other thing I said was if I had an ulcer, a stage 4 decubitus, that's a type of ulcer, a bed sore, that actually goes all the way to your bone. And this can happen in nursing facilities, and you see it all the time. And if I have that basically means I haven't been moving. I haven't been, I have really very little chance of doing well. So in that circumstance, don't keep me alive unless I have a traumatic brain injury that hopefully I can come out of, but maybe not. So, and then the third one is what you would want, which is nice because it gives an indication about how people around you care for you. And this is something I think the medical profession and also family members should think about, how comfortable do you want to be at the end of your life? And basically, I'll go through different aspects of this. Basically, the first one says, I don't want to be in pain. I want my doctor to give me enough medicine to relieve my pain. If I show signs of depression, nausea, shortness of breath, I want caregivers to help me treat that. If I feel hot or if I'm sweating, if I have a fever, I want a cool, moist cloth to be put on my head. Sometimes what you see is when people come toward the end of their lives, their mouths get very dry and crusty. I want that to be cleaned off. This is a directive to the healthcare field. This is what I want. I don't want to have this. It's uncomfortable to have that. I like the next one, and I wish to have warm baths often. I wish to be kept fresh and clean at all times. I like that. And the next one's even better. I wish to be massaged with warm oils as often as I can be. I'm going to sign up for this right now, because that sounds really good. And then other things, I want to have my favorite music played. I want to be groomed to some degree. I want to be shaved if necessary. I want my teeth brushed. I want to have some, at the end of my life, poems read. And you can select what kind of poetry you want to have read at the end of your life. Well, you think if we spend 1/3 of our healthcare dollars on the end of, on the last 2 years of our life, you think that maybe some of that could be, some of that care can be given.
Listen, I used to be in assisted living. The last 2 months of your life, I think the expenses are extraordinary.
Yeah.
Has this issue of cognition been changed in the last 5 or 6 years?
No, it's still, it's the same. And then, so now this is a directive more to, how you want to be treated. I wish to have people with me when possible. I want someone to be with me when it seems that death may come. You may not want that. You may want to die alone. You may want to, I want to be at, my own space. That's people's choice. I wish to have my hand held, to be talked to when possible. I wish to have others by my side praying for me when possible. I wish to have members of my faith community told that I am sick and asked to pray for me and visit me. I wish to be cared for with kindness and cheerfulness and not sadness. I wish to have pictures of my loved ones in my room, near my bed. And then I want to die in my home if that can be done. And then what you want your loved ones to know. You know, this all seems obvious. You know, I wish to have my family and friends know that I love them. I wish to be forgiven for the times that I've hurt my family, friends, and others. I wish to have my family, friends, and others know that I forgive them for when they may have hurt me. That I forget, you know, that's forgiven. That it's water underneath a bridge. You know, and that the wish also is that they're at peace with each other and before death. That there's not fightings about money and how much more mom or dad loved me versus you. That you want them to all get along. They didn't get along when they were kids, and they may not ever get along, but get along to some degree. And so these are things that you can cross out, you can add on the things that you want. And then there's also the last ones where what you want to have done with your body. Yes?
Okay, would it be possible for you to just write a statement as to what you want?
Yes.
And do you have to have it notarized?
Yes, that would be, you would have to have it witnessed.
Okay, and okay, say someone is in a nursing home. You leave that there, what about the medical doctor? Do you have a copy at the hospital?
Let me go back. If you're doing your own statement, you'd have to have it notarized if you're doing your own statement. For the California, it's just having it witnessed. For the California state, it's having it witnessed. Yes.
Is the original more important than a copy? Do they accept copies?
Yeah, I mean, and what's important is if you do one of these, you give it to your doctor. And what's great about our current medical system is everything's electronic, so it gets scanned, it's in the system, it's under advanced directives, and then a doctor in the hospital says, oh, there's their advanced directive right there. I'll pull it up right here.
I was wondering if you're in hospice, and I'm thinking more about some of the massage stuff, being kept clean. Do the hospice people help with that?
Hospice is a lot more caring. I find that they do a lot of that type of caring, and there are. It's a growing field, and there are other types of hospice organizations that give a lot more toward the end. There are ones that actually do a living funeral for you. You basically have your own funeral before you die, and people come and they pay their respects to you before you pass.
So I guess it seems like it might be good to sort of find out about hospices and things and, decide on one and things.
Right. I mean, especially if you have a condition, if you're diagnosed with a cancer, or if you're diagnosed with heart failure, or these are, or have had major, problems where you know that years down the line, this is not going to go in the right direction, or it's not going to go in the direction of living. It's going to go in the direction more toward death. So then you can write your own things at the bottom of what you want to say to your loved ones. I said all living things live and die. I'm just one of those things. So that was my advanced directive. So there's also the POLST form. Now, the POLST form is like the nitty-gritty. This is you just want you're close to the end or near to the end, and you want. This is what you would want. It's a very simple document, and it's actually a very good document to have. And this is a form that you can actually put in your house. You can tape it onto the refrigerator door. You could your doctor may have a copy of it. If you're in a nursing facilities, a lot of them will have a POLST form for you if you were transferred to the hospital. So this is the POLST form. Beautiful pink coloring. It's really nice. But it's bright, so everyone can see it. So basically, there are 3 different portions about what you would want here. So basically, CPR. CPR being someone doing chest compressions or shocking you out of an abnormal heart rhythm, or if you don't have any heart rhythm, shocking you in trying to get your rhythm back. So there's attempt resuscitation, do not attempt resuscitation. Basically, very simple. Attempt, do not attempt for that, CPR. So that's the first portion of it. The second portion of it is, okay, well, what kind of interventions would I want? Would I want, if, let's say I had a major infection, would I want just comfort measures only? Just let me go. Don't treat me with antibiotics. Don't just make me comfortable. Don't give me anything that's gonna, well, I mean, you can get antibiotics, but don't maybe give me IV fluids and try to keep me alive if the end is near. More comfort measures. But you can choose that. You can choose limited interventions like antibiotics, IV fluids, but don't put me on a ventilator. Don't put me on a breathing machine. I don't want to be on a breathing machine. Or you can make the choice of just full treatment. Just get me out of that abnormal heart rhythm, shock me, intubate me. I've watched ER. I've watched Grey's Anatomy. I want that. And then that's that portion. And then the other portion is artificially administered nutrition. I don't want it. That's no artificial nutrition. I want a long-term artificial nutrition by tube, or I define a trial period of artificial nutrition by tube. So you can add like, okay, well, I want artificial nutrition maybe for 2 or 3 weeks, but I don't want to have a feeding tube for a year. I don't want it for 3 months. So you can make those choices. And then this has to be signed by the doctor. And I've signed a few of these. So that's the POLST form. Any questions on that?
How does it fit in with the 5 wishes material? Do you keep that at home for people in that family? The 5 wishes?
Yeah, you keep that, but the doctor should have a copy of that too. Yes. So, ask your doctor. The Affordable Care Act of 2010 allows for doctors to talk about it. Wonderful doctors get paid for talking about it. There's no such thing as death panels. And then provide a copy of the advance directive to your doctor. So then this brings the whole notion of hospice. So when you come to the end, this is a great organization, a great service that can be given to you. It's a philosophy of care that focuses on palliating your symptoms for terminally ill patients, people who have difficulty with their breathing, people have difficulty with mucus in their mouth, suctioning the stuff in their mouth. People have nausea. They treat the end-of-life issues that happen. In 2012, 1.6 million people received hospice care in the United States. And these numbers are just going up and up and up. A fraction of that 10 years prior. So it's more people are realizing the benefits of hospice. No, hospice can be done in a hospice facility. It can be done in a nursing home. Usually it's more, they do more palliative care, but it can, they can have, no, it's really not done in a hospital. It's more like a hospice, it's a hospice unit that they do it in. So to qualify for it, it's basically you have to have two physicians who say, well, we think this person has about 6 months to live. And we don't see the person living beyond 6 months. Of course, that's somewhat of an arbitrary number, and people can live beyond it, and some people live much less than that 6 month interval.
How do you get two doctors? Or what if you only have one? Where's the other one come from?
That's interesting. So the other one sometimes comes from the hospice, because there's a doctor supervising for the hospice service. So the hospice doctor can be the second person. And it's not just for you. It's for the family members too. So hospice is also something where the caregivers in your family, your daughters and sons who are having difficulty, there's a lot of support from hospice, and it's really good for them. It really helps them out with the suffering at the end of your life, at the end of the family member's life. So I said it could be provided in the home, nursing facility, hospice unit, or within an assisted living facility. So facts about hospice. So one thing is decreased symptom distress. So you have 6 months to live. The thought is you have 6 months. You're suffering less in that time frame that you're in hospice. The people that are on hospice, there is the family and the person that's on hospice has a great degree of satisfaction with the service that it gives. You're less likely to go to the ICU, the intensive care unit, and you have a lower chance of dying in the hospital. In 2012, 66% of those who died under hospice care died in the home, more toward that 70% number that people want. And then the savings, you save a lot of money by not going to the hospital, by not going in the ICU, and not getting this very expensive state-of-the-art care that you get there. Even if you do hospice 1 to 7 days prior to your death, there's a savings of up to $2,620. And that goes up 8 to 14 days, and even goes up higher 15 to 30 days prior to your death. It goes down there afterwards because you've been on hospice for a long time, so you're getting a lot of care from hospice. But you're still saving a lot of money. And you're saving the system a lot of money. And no one likes to think about these things, but it is a savings that can be saved for other things. The savings to Medicare can be $5 to $10 billion, and that's not any small amount.
Does the patients fill this out this time in our lives, or do they fill this out for hospice? Who does that?
Well, it's usually a choice that's made by the patient, and with consultation with the family. She was asking who makes that choice about hospice. Usually, it's given as by the doctor or even the family says, I think we should go on hospice. And then you call a hospice coordinator, and you call them, and they talk to you about the service. And then you can decide if you want to do the service or not. Well, but a lot of dying patients are able to make those decisions too. Yes?
How do you choose a hospice?
It's a good question. I mean, it's hard to say because there are many out there, and I don't know if there's in regards to like how many stars it has on Google. It's hard to say because but you have to look it up. I mean, there are some hospice services I like better than other hospice services. Some that are hospice services are smaller and more well run than the larger ones. So it's sometimes difficult. There was a question in the way back?
Yes, several questions, please.
Yes.
Do you have to be DNR to qualify to stay on hospice, DNR?
Well, basically, you have to actually, I think, for resuscitative measures, you can change that. But I think it's the thought is if you go into the hospital, the whole idea of it is, you're coming toward the end, so you come to the conclusion that most people come to the conclusion that they want to be do not resuscitate. I don't think you have to be do not resuscitate, because I think sometimes people make choices at that in the realm when they're in the hospital that they want to be resuscitated. So I don't think you have to be DNR, but I think most people, the majority, are. Yes?
I think I can answer that, doctor. I've done hospice volunteer work for over 30 years. When I did it in Virginia, I saw one time we did have someone who wanted to be resuscitated. Hospice then calls someone else. They won't do it.
Hospice won't do it. But the hospital would do it. Right. The hospital, no, hospice doesn't do the hospice service won't do it.
Yeah, they'll provide your wishes, but they won't particularly do it themselves.
No, hospice won't do that. No, it has to be done, it would be done in the hospital.
Is this an additional cost if you're in the hospital or a facility? Hospice is an additional cost, is that?
No, hospice, often it's a service covered by Medicare. It's a service covered by Medicare. So, yes. Yes.
Should advance directives be redone every so often? Do they ever look at it and say it's too old?
No, but with my traumatic brain injury, when I'm like 80 years old, I mean, dude, he's not. We're not gonna try. I think it's a good idea to do it. Yes, I think. I think it's a good idea to look at it, to review it after the age of 65, every 5 years, to see is this really what I want? Does this, because it's good to review, because how you felt 5 years ago may not be how you feel now.
What I'm asking then is there's no expiration date.
Not that I know of. Yes?
Just a quick comment. Your relationships with whoever's representing you can change too, and I'm in the process of having looked at my family and decided that no one's really the right person and going to a friend. So it's good to keep that evolution in mind as well, because things happen.
Yes.
Do you need both an advanced care directive and a post?
No. But it's when you're coming to, when you think, okay, well, if something were to happen to me, and I'm thinking that maybe soon it may happen to me, a POLST form is a good idea to have.
Like when my mom was really sick, they put her on the wall in the hospital room.
They put the POLST form, yes.
That was the first time she ever did it.
Right.
I have long-term care insurance, and I wondered, well, long-term obviously can be more than 6 months, but if you went to hospice, then does long-term care, do different things than hospice?
My mother-in-law has long-term care, and I don't even know. I don't know how it affects the hospice aspects of it. Yes.
Medicare will pay for hospice for what length period of time?
Well, there's that 6-month interval, and then the whole question is, do you renew the hospice? Do you continue it? There's Art Buchwald was a famous author. He was on hospice, and he kept having to renew the hospice because he kept living, and he would live there. He had kidney failure.
Is that acceptable to Medicare? They will keep on paying?
Yeah, they will keep on paying. If you do hospice again, they'll keep paying. So.
Savings for? Who gets the savings from this?
Well, in some degree, the individual gets the savings because there's 20. You're paying 20 if you're just straight Medicare. You're paying 20% of the cost of hospitalization. So your family and you are saving that money. to some degree. But Medicare also saves the money.
Health insurance will continue paying.
Right. Well, yeah. It's a Medicare benefit. So this is hospice care is different than. Oh, I'm sorry.
Accidents happen many times. You are somewhere in another country or in another state. Should you have this document with you when you travel?
I think it's a good idea to have it, especially if you think something's going to happen. But it's hard. I think it's a good idea if somebody, the agent that you've made your durable power, that if that agent has it, they have it, and they know something that's happened to you, they'll be informed and they'll have a copy of that form. So hospice is different than palliative care. The palliative care is often done, and this is becoming more common in the hospital, when a person is in a grave state, but they're not wanting hospice right then and there. And basically palliative care is just addressing a lot of the issues that come toward the end of life, the emotional and social issues, the family issues. And you're seeing this a lot more. And so if you're ever hospitalized, you may come, a palliative care doctor or nurse may come and talk to you more about if things are severe and they're not going the right direction, they may talk to you more about what your wishes would be, what would you want. This was not done, when I started medicine, this was not done. People didn't have these services, and I think it's a good thing to have, because I've seen cases where people have been in nursing facilities for years, 5, 6 years, tethered to a bed on a ventilator, and no chance of coming out of it. And no one really had that discussion with them before, and there was no real discussion prior to that happening. And that's happening a lot more.
So these are for people who don't have 5 wishes or.
Oh, that's for those cases are people that, or the cases where they want to have everything done, and the family members and the medical system cannot let go. So it's difficult. As a doctor, it's difficult to talk about these issues because, as a doctor, you want to cure everything. You're going to make everything better. You're going to fix death. But you're not, as a doctor, you can't cure death. Death is, everyone dies, and you're not going to cure it. But even in situations, even when life-limiting situations, doctors have a difficult time talking to their patients about advanced directives. The conversation only happens 40 to 45% of the time. So it's not something that doctors think about in the front of their mind. They're thinking about fixing things. They're thinking about giving you medicines to make you feel better, or doing that surgery that's going to cure everything. They did an interesting study. It was a hypothetical study, and it was done in the emergency room. It was hypothetical of a cancer patient who had gastric cancer that was metastasized throughout his whole body and was coming into the emergency room with nausea and vomiting. And what they did a study about how doctors responded to these patients, and only 43% of the time, only 43% of the time did doctors actually ascertain what the patient knew about their illness or where this was going. Only 43% of the time. And this was a situation where a person was having difficulty breathing and shortness of breath. In that situation, 9% of the doctors actually just said, we're just going to put this patient on a ventilator, without even asking what would they want. So doctors are not perfect in regards to this.
On the ventilator, the patient speak, and his patient talk?
Well, if the ventilators, if you know the tube's in your mouth, no, you can't talk.
What about your oath?
Do no harm. Yeah, the oath is. I mean, people think that if you do heroic measures, that's doing no harm, but sometimes that is doing harm. Sometimes doing chest compressions, sometimes shocking a person out of trying to get them to come back is sometimes doing more harm. Yes.
How can that be a hypothetical study?
It was done in the emergency room, and it was done with a woman and a man. And the man had metastatic gastric cancer, and they were told this. What would you do in this situation? But it wasn't like the patient was actively. It was hypothetical because it was an actual patient that was actually dying in front of them. But it was a role play that they were doing with the doctors. Okay, so the most important thing, and what I often say is, okay, so we all die, and the whole idea is to be at peace with the whole process of life and what we go through. And while as at the beginning I said it's befuddled to know what the whole thing is about. But if there's something you want to do in life, if there's something that you've always wanted to say or be or do, I mean, live as though the day were here. Live as though the moment was here. Because to wait until your deathbed is too late, especially with those you care about, those you love. To be able to say to those people, that you care about them, or not even say to them, but with the intention of it. So live as though the day were here. I wanted to bring up a good book. It's called Being Mortal. I don't know if you've heard of this book, Atul Gawande. He goes through a lot of situations of end of life and the struggles that people have with the end of life. And I just read this a few months ago, and it was really very, very well done. And just what these whole things are, the whole hospice, skilled nursing facilities, assisted living, he discusses all these things in a very well thought out manner. So I definitely recommend this as a good book to read. I wrote my own book, but a situation, he has situations where people have family members who are caring and really care. But I wrote a situation about a person who doesn't have family members who are there for him and wakes up tethered to a ventilator after a stroke, and what that's like and what that experience is like for him. And my book it's called Beautifully Absurd. And so it was really it pays homage to the people of the 60s and that generation of people and the struggles that they went through, the whole civil rights era and the whole Vietnam era, and how these people changed our world in so many ways. Very self-righteous, and very self-conscious and very maybe self-serving in many ways. And what would happen to these people as they get older? And this generation of Americans that's now the baby boom generation that's getting to be over age 65. And what's going to happen? That generation that tried to free their minds and all you need is love, and that whole generation of people. And you think about what they were and who they were, and for some reason these people still think that they're these people, but they're not. It's changed. And, and just to that generation, and just to make them realize that, maybe they should be thinking about this too. Because, they were the ones that try to change things and open their minds, and they're searching for some meaning and some answer to everything, and some of them are still searching. But what happens? So that was sort of a plug for what I wrote, and what it's like. So I mentioned these where you can get the five wishes. It's www.compassionandchoices.org. Oh yeah, just do the first one was for the 5 wishes. There are other ones, other organizations. www.agingwithdignity.org. These are different organizations that help in regards to end-of-life issues. Roger Weisberg, that was actually a PBS special, Money in Medicine, which it makes you realize what a strain it is on hospitals and patients when end-of-life discussions are not made.
Is that a book too?
No. That's an online. And then also, if you, caregivers, if you need caregivers, is a www.caregiver.org. The last thing, I'm sorry. For what? For the compassionandchoices.org, it used to cost like $5 for the 5 wishes form. For the Roger Weisberg PBS, I think actually it does cost money if you want to buy it as a video. But I think you also can get it on PBS Online. The only other plug I have is another. There's a lot of good books about dying. It's a great field. But it's called "It's Okay to Die," but this gives different. It gives a sort of what you would think about in different situations about what you would want. It's by Monica Williams Murphy.
What was the title?
It's Okay to Die. You can get it on Amazon.
You're recommending that?
Yes. POLST forms should be in your doctor's office. They should have them. And yeah.
Did you give her name?
Oh, Monica Williams Murphy.
Is Dr. being born children, it's okay to die. My girlfriend, she passed away about 8 months ago, and her daughter is still struggling. Is this a good book you recommend for her?
Well, I mean, it's after the whole process. I think they have a lot of grief support groups regarding, like grief support groups. They have support groups for family members who have.
She's been in grief support groups.
It hasn't.
Not one. And yet her mother was in cancers. She knew it was coming.
Right.
She was there when her mom died. And this has been tremendous experience for her.
And that's a hard thing. I mean, it's a hard thing to confront. I mean, we think of our world as being here forever. We think. I mean, we have roads. We have Westwood Boulevard. We have Pico Boulevard. We have buildings that are here. These edifices that we think that this world is permanent. And it's anything but that. And it's hard to. We think the people around us are permanent also, and we just have a difficulty letting go of those things, and difficulty letting go ourselves. Yes.
Is a copy of the advance care directive legal?
Yes.
A copy of yours?
Because I mean, you put one in the chart.
You can carry around a copy.
Oh yes.
And that's okay.
Yes.
For signature.
Yes.
How do you get that?
For?
A lawyer to make like a living will or a living trust? You know, there's no shortage of lawyers. I mean, I think there. I just don't know. I mean, I can't really recommend one versus the other, but there. Yes.
The person doesn't have an advance directive, and then they're in a situation where they can't make a decision, and will not accept
No, they would. They would. They would. Yeah, they would say, well, what would your mother want? You know, what would? No, my mom wouldn't want to be kept alive like this. You know, they would follow that. Yes.
Do you know about the Oregon Death or Dying Act, and
Yes.
is that direct euthanasia?
Yes, I mean that's more directed. You know, if a person has a condition where either they are severely debilitated, or if they're close to dying, it gives them the right to actually, basically, be euthanized. So that's. But I think it's also there's a determination in regards to what how the doctor feels, or I don't know how many doctors need to actually be on board in regards to that. I don't know the specifics in regards to that, but it allows for euthanasia. In that.
It basically allows a physician to prescribe a drug that someone would take to put themselves to sleep permanently.
Right.
There's nothing to do.
No, I don't. That's not an advanced directive. All right. All right. All right. Thank you.